Hello, my name is James Blair. I'm an orthopedic trauma surgeon practicing in Atlanta, Georgia. My practice is mainly focusing on limb salvage and post-traumatic deformity correction. Here to talk to you guys about the treatment of critical size segmental bone defects. The hardest part about figuring out a critical size bone defect is really just getting the definition, and that's something that we still have difficulty with today. Really, the best definition is you have a patient with a bone loss and you fix it as you normally would, and if it went on to heal without any other intervention, then that wasn't a critical size segmental bone defect. And if it doesn't heal, then it was. But the difficulty in trying to figure out which is which has been difficult. But in those with obvious critical size segmental bone defects, and specifically we'll talk about the femur, there's a couple different options that we have to treat those. And I think that some of the first options that most of us are familiar with are bone grafting in an induced membrane after placement of a cement spacer, otherwise known as the Masquelet technique. And I think that that has proven to be successful in many cases. However, it can be inconsistent with the number of procedures that requires to get to union. Other options are, of course, amputation, but that's not going to be a very good option for a lot of patients, and I know a lot of my patients are seeking options other than amputation. And then I think that the most consistent way to treat these difficult injuries is with bone transport. Traditionally, bone transport has been done with circular external fixation or other types of external fixation, and in the femur, it's very poorly tolerated. Sometimes it's the only option, but there's been developments in other ways of treating this. One of the different things that we'll talk about today is the use of plate-assisted bone segment transport, or the PABST technique. That is an all-internal technique to utilize and harness the power of a lengthening nail, but in a static bone that is not changing in length.
So in this example, we're going to simulate an 80 millimeter distal diaphyseal femoral defect, as you can see in these fluoroscopy images, and also depicted in this sawbones model. So with this distal diaphyseal defect, there's a number of ways that we can treat this with a plate-assisted bone segment transport. One option is to use a retrograde lengthening nail that will be completely extended out, placed here with a proximal corticotomy, pulling this transporting segment down and closing down the gap. You can alternatively use an antegrade nail, similarly as depicted here, in which a push technique is used to move the transporting segment down and closing down this gap. The decision then is which plate to use, and in both cases you can use a distally based plate that spans the entire length of the bone, or you can use a proximally based plate that can be depicted as such there. And so in both of these instances, we can use this technology and use this technique to treat these very difficult defects. Let's get started. In this case, we decided to do a retrograde lengthening nail that will be fully extended, that will retract for a pull technique to close down the defect. We've also decided that we are going to use a distal femur plate that is going to span the bone, something to that effect. And it is also helpful to have a plate that's got some different options as far as screw configurations, because inevitably we're going to be shooting screws around the nail and around an eventual trauma nail when we replace this. Go back to the other view. So we will use a standard retrograde nail start point, and we'll use this to get our opening reamer for the lengthening nail. And we're doing this first, go ahead, because we are doing a pull technique. Okay, I'll take the opening reamer. So this is simulating approximately where a 245 millimeter nail would be. And so we know that we can extend the nail proximally up to the level of the lesser trochanter, but we still need to have enough space to place our corticotomy. As we get our plate sized up, image there. Okay, now come up to the proximal hip. There you go, image there. We can see where the nail in its fully retracted position would be in relation to the plate. And we will ream both the distal segment as well as the proximal segment. You can come back distally. So in the scenario of using a pull technique, I have the opportunity to not ream where the corticotomy is going to be. And so knowing that my corticotomy is going to be more proximal than this, I would prefer not to ream that and leave it as such. So I have our lengthening nail here, and knowing that we want to use a pull technique, this means I need to extend this nail almost as far as it can go, and we can use that intraoperatively using a magnet in this case. And so we will run this forward to distract this nail as much as possible. So now we have the lengthening nail completely extracted, as you can see here. So at this point, we can proceed with the insertion. We will remove the ball tip guide wire, and we will insert the nail, being mindful of our overall alignment. So one advantage of using a pull technique in a plate-assisted bone segment transport is that maintaining coronal and sagittal plane alignment is a little bit easier. There's only one place for the transporting segment to go. It's going to go towards the nail. And so now we will place interlocking screws both distally and proximally. We'll figure out where the corticotomy is going to go, and then we're going to place our plates. So with our interlocking screws in place, now we have some more stability of the fracture and of the femur. We can overlay where the plate's going to come in. Come on, distally, please. And then understand where our corticotomy will ultimately be. Image there, please. Come distal a little bit more, fluoro. Right there, shot that. You can see we put the screws in from medial to lateral so as not to impose and impede onto the plate. Now show me proximally. Can I see a tonsil, please? Right there is good, yeah. And so we can see that we have plenty of screw fixation proximal to the nail. Our corticotomy will be, image there, somewhere around here. It can be anywhere from the most proximal aspect of the nail to the most distal aspect of the screw cluster more proximally. Why don't you come just a little bit more distal with fluoro, and give me an image there, please. And so I think about there is where our corticotomy will be. See a marking pen, we'll put a mark right there. Okay, can I see a knife, please? And we'll start. So now at this point, now that I know where the corticotomy is going to be, we can make all of our holes for our corticotomy, but we will not complete it just yet until we get the plate definitively placed. So now I will make as many holes as I can, and I typically like to do this under fluoroscopy to make sure that our holes are going to be perpendicular to the anatomic axis of the femur. So with all the provisional holes of our corticotomy made, we can complete the corticotomy with the osteotome. Completion of the corticotomy is confirmed with translation of the cortical widths. So you can see we have now displaced the corticotomy slightly, and we will now reduce it back into its position. It is relatively stable in this case because we have the external fixator and because we have an interlocking screw in the Precice nail. Shot there? Okay, see a knife, please? Now we can place our plates that will span the length of the femur for our final part of our construct. So you can see the corticotomy just proximal to the interlocking screw. We have plenty of screw holes proximally. As this plate is now sitting in a good position on the lateral, come up to back up to the AP, we will fix the position proximally, and then we will start placing screws through the plates. It's important to note that all of the screws in the proximal segment in this case should be locking screws. I don't want to bring the plate too close to the bone. I need to have a little bit of space between the transporting segment and the plate in order to make sure that the transporting segment can actually move. If we use cortical screws up top, then we run the risk of having too much friction and for the nail to have difficulty transporting the segment. So having the ability to place locking screws at variable angles will really help get screw fixation around the path of the nail. So now with all of our screw fixation that we're going to use both proximally and distally, you can show me distally down here now. Our main fixation is complete. At this point, we can take the jig off of the lengthening nail, we can take our external fixator off, and we can test the nail to make sure that it is working. So now we can test our nail, come distal, and let me see a tonsil. Image there. And so in this case, the darkest part of that nail is where the magnet lies, which is approximately, image there, right there. So we will take our magnet and we will run our magnet in reverse. So come back here approximately. So I'll overlay the magnet directly over the internal magnet, image there. And I don't want him to move, and all I want to see is the corticotomy move a little bit, and we will run this now for about 45 seconds. Now with a little bit of space between the plate and the bone, we will run the magnet again. And now we have definitive movement of the corticotomy. Now we know the nail is working, the system is going to function, so we will now place the corticotomy back to where it was by running the nail forward in this case for an additional 45 seconds to replace the corticotomy where it was before. There we go. Okay. So now with our construct final, we can simulate what this entire system will look like with the entire transport done. So at this point, we have maxed out the amount of transport that we can achieve with this nail. But we still have a gap. So now we need to do what is known as a recharge, in which we will stabilize the transporting segment with some small unicortical screws. We'll remove the proximal interlocking screw from the nail. We'll run the nail back forward and then re-grab the transporting segment with the new interlocking screw and complete the transport. We would do this in a separate case in the operating room as an outpatient. So now that the proximal interlocking screw in the lengthening nail is removed, we have to have locking screws through the plate, or else the transporting segment will rebound up with the immature regenerate. Now we can recharge the nail, lengthen it back out, and we'll put a new interlocking screw in proximally to continue the transport. Now that the nail has been re-lengthened, we can put another interlocking screw in to continue the retrograde transport. Now that a new interlocking screw is in place, we will remove the temporary locking screws in the transporting segment, which will allow us to continue to move the transporting segment. So at this point, now that our transport is docked, I want to do a docking site procedure, which means I'm going to debride out all the scar tissue that is formed right at the docking site, and I'm going to remove the lengthening nail and replace it with a trauma nail. And this is something that I would normally do in my practice right as the bone is docked. I typically don't like to wait because I think the patients want to get moving faster, and it makes me feel a little bit better that I can get the docking site debrided to get all the scar tissue out. So we will make an incision on the anterolateral aspect, and in this specimen, the plate is a little bit anterior, so we will cheat our incision slightly anteriorly. We will dissect up and over the plate. And in this specimen, I can feel the docking site as it is right about here. And we will place some retractors. And so I can get a curette and a rongeur, and I can clean all of the scar tissue that may have formed. I can deposit bone graft if I choose right here. Sometimes if there's a small gap, I can run the nail in the operating room and compress even more. But now that I have this docking site here debrided, now I think this gives us the best chance of getting a docking site union. So we can come out with these two. Before I remove the lengthening nail, I will need to secure the transporting segment, because in this immature regenerate, it will spring back. So we'll put one or two more unicortical locking screws in this plate to hold the transporting segment. Now with all of our interlocking screws removed, we can remove the lengthening nail. The plate, as it has spanned the entirety of the femur, is still maintaining all of our alignment, and the unicortical locking screws in the transporting segment will prevent the transporting segment from springing back and rebounding. Image there, please. With the lengthening nail removed, we can now place our ball tip guide wire for our standard trauma nail. We will ream as we normally would for a intramedullary nail. Image there. Shot again. Okay. Placing the intramedullary nail allows us to span the regenerate, which protects it during its maturation and may allow for earlier weight bearing. And our docking site has maintained its position because of the unicortical screws we placed through the plate. Now with the final interlocking screws in the trauma nail, our procedure is complete. The patient has grown the new bone, the regenerate will mature, and we will allow weight bearing in about 6 to 8 weeks.
So what we just saw was a pull technique using a retrograde lengthening nail with a distal femoral plate to treat an 80 to 85 millimeter defect in the distal femoral diaphysis. The key takeaways from that procedure are that preoperative planning is crucial, and that without preoperative planning, you will not be set up for success. And this includes measurements of the length of the bone, the length of the proximal and distal articular segments, the length of the defect. And also with preoperative planning, it is important to know what is available at your institution and your hospital as far as lengthening nails are concerned, or just the length of the distal femoral plates or proximal femoral plates that you have. There are instances in which a patient's anatomy is not going to be amenable to the implants that you have at your hospital, and that happens from time to time. And being able to think through what your construct will look like at the end of the transport process will be critical in being able to identify issues that may happen during the transport process when you're doing the procedure intraoperatively. And equally as critical is testing the nail intraoperatively to make sure that your corticotomy is complete and to make sure that your system works. As you saw in our example, we had issues with the initial transport, and that required some troubleshooting, and that happens from time to time. So I hope that this was helpful, and I thank you all for joining us today.